Hey everyone, Ryan here, and welcome back to our Pediatric Dentistry series. In this video, we're going to talk about developmental disturbances of teeth. Now, in the last video, we spent a lot of time unpacking the process of tooth development, and I briefly mentioned defects that could occur due to disturbances during certain parts of that process. And now we're going to unpack more specifics about these developmental disturbances. So our first category are anomalies of tooth number. Now, this kind of disturbance occurs during the initiation or bud stage, where you get either extra or completely missing teeth. So supernumerary or extra teeth occur in about 3% of the population. The most common form of this is what's called a mesiodens, which means middle tooth. And this is an extra tooth that occurs at the midline between tooth number 8 and 9, and most mesiodens are palatally positioned. Now, supernumerary teeth may block normal eruption of permanent teeth, and so sometimes it's necessary to take those extra teeth out to prevent impaction of the normal permanent teeth. Now, here's an example of a cleidocranial dysplasia patient with multiple supernumerary teeth and unerupted teeth as well. Now, we also can have congenitally missing teeth that are just not present. Now, this is the correct order for most commonly congenitally absent teeth. So after third molars, it's lower second premolars, then upper lateral incisors, then upper second premolars. I swapped these two in our oral surgery series, but I addressed that in the comments, and this is definitely the correct order from most to least common congenitally missing teeth, and that is definitely important to know for the board exam. Now, if you have a second premolar that's missing, you can attempt to close spaces with extraction treatment to make the arch form symmetrical. So what that means is if a patient's missing a second premolar on one side, and they could benefit from extraction therapy if they have crowding or some other reason, you could extract the second premolar on the other side and attempt to close space reciprocally so you can keep midlines on and not mess up their bite. But sometimes if they're missing, say, both second premolars, or they're missing all 4 second premolars, it might be really difficult to try to mesialize those molars and close that space. Sometimes you have to, if the patient's up for it, prepare for 4 implants or bridges or some sort of prosthesis to replace those missing teeth. Now, with lateral incisors, it's a little bit easier in terms of what we would decide to do. Most commonly, you'd either have canine substitution, where you bring the canines mesially to close space, and then you perform enameloplasty on them to make them appear more like a lateral incisor. Or you can do a prosthetic replacement, like a Maryland bridge or a conservative prep bridge that can replace those lateral incisors. As far as the primary dentition, primary maxillary lateral incisors are the most common congenitally missing primary tooth. So maxillary laterals are definitely some of the more common ones that we see missing. Now, it may not surprise you that the most common ankylosed primary tooth is the lower E, or the primary mandibular second molar, which this tooth, the mandibular second premolar, replaces. So there's certainly a connection between that statistic and this statistic. All right, so now we have anomalies of size. The first 2 of these occur in a disturbance during the bell stage, whereas these 2 occur due to a disturbance in the cap stage. So we're going to start with microdontia, which simply means small teeth. And so we have 2 general forms of this. It can be a generalized form that affects all the teeth, so all of the teeth would be small. We see this in some Down syndrome patients, pituitary dwarfism, and ectodermal dysplasia. Or this can manifest in a localized form, where you have isolated instances like one tooth or two teeth or just a couple. And this most commonly includes the peg-shaped maxillary lateral, or peg lateral that you can see right here. Peg laterals are often transmitted as an autosomal dominant trait, interestingly enough, but it has variable expressivity and incomplete penetrance, which means if your parents have them, it doesn't necessarily mean you're going to have them or have them to this degree of severity. And the opposite of this, we have Macrodontia, which simply means big teeth. Now this excludes fusion and gemination, which we'll talk about in the next two slides, respectively. Now this one can also occur in two forms. We have generalized, where all the teeth are large, and this is very, very rare that we see this. This can be with pituitary gigantism or pineal hyperplasia with hyperinsulinism. Again, very, very rare that you see this. More common, which is also rare, but more common relative to the generalized form, is a localized instance where you have just one tooth like you see down here that's larger than all the others. And we can see this in hemifacial hyperplasia. All right, so fusion is where two buds merge into one tooth. Or better yet, I should say two adjacent caps merge together early on in tooth development to create one tooth entity. Now, interestingly enough, these two fused teeth still have separate canals. So they're each going to have their own separate root canal. It's most common in primary teeth. It almost always affects anterior teeth in both primary and permanent dentition. And the tooth count is one less than normal. Because if you think about it, these two lower incisors merge into one tooth entity that you can see over here in this patient. So if we count this as one tooth entity, this patient only has 1, 2, 3 lower incisors. And the board examiners love to ask about that for whatever reason. The counterpart to that is gemination, which is described as a root that splits into two crowns. But since we better understand odontogenesis and tooth development, we know this really has more to do with early splitting of a tooth bud or tooth cap, but it still maintains just one root. So as a result, this kind of tooth is going to share one root canal. You can remember gemination because the Gemini zodiac symbol is the twins. So when you see Gemini, think twinning, which is actually just another name for gemination. Also, if you think about the tooth development process and how these occur, the names kind of make sense to the process that's occurring. Either the tooth caps are fusing, or the tooth caps, or a tooth cap is twinning or splitting into two. So this time, the patient actually has a normal number of discrete tooth entities. So in this patient, here's an example of actually two teeth that have undergone gemination. And if we count their teeth as tooth entities, we're going to have 1, 2, 3, 4 upper incisors, which is normal. So that makes sense. And if you're curious to treat something like this, you could potentially do a conservative restoration if the patient was concerned about aesthetics, but otherwise no treatment is necessary. All right, our next category is anomalies of shape, and we'll talk about these four in the next slides. So dens Evaginatus is an extra cusp, and that extra cusp contains all the tooth material you would expect it to contain: enamel, dentin, and pulp. It's not just a bulge of enamel. This is literally an extra cusp. So, why does that matter? Because we have to be careful with operative procedures. If they have caries involving an extra cusp, we can't just drop the burr farther than we would normally because there is most likely a pulp horn associated with that extra cusp. So we have to stay in tune with that. So we often see these volcanoes coming up from the center of lower premolar crowns. Again, this is a rare thing to see, but if we do see it, it's most often found in lower premolars or incisors, as we'll soon talk about. But this is kind of like a volcano in the center of the crown, and if it occurs on the lingual surface of an incisor, right by the cingulum area, that's called a talon cusp, just another form of dens evaginatus. Then we also have the counterpart to that, which is dens invaginatus, or dens in dente, which literally translates to tooth within a tooth. So what does that mean? Well, the name kind of gives it away. It's caused by an invagination of inner enamel epithelium. But now you see why I talked about tooth development first, because we have now an understanding of what that means. So if we have an invagination of IEE, which becomes ameloblasts, which eventually secretes the ultimate enamel, we're expecting some kind of invagination of enamel, and that's exactly what we see. So it creates essentially a hole in the enamel and then forms a tunnel through the tooth. Why is this important? Well, caries can progress very quickly through that tunnel, which is not a good thing. It's most commonly seen in permanent maxillary laterals. So our maxillary laterals are coming up a whole lot in this video in terms of things that can go wrong with them. And that's true. I don't know if there's some sort of genetic link there, but they're definitely the star of the show in much of these diagnoses, unfortunately. Now, because this is an internal problem, we need a radiograph to diagnose this, and you can really appreciate what's going on here. Perhaps if I erase some of these things, and you can kind of see how it might look like a tooth sitting inside this tooth. It's really funky looking. It's because of that tunnel splitting the root in essentially two parts, causing a funky looking tooth in the center. All right, next we have Taurodontism. Tauro meaning bull, dont again meaning tooth. So perhaps this looks more like a cow's or bull's tooth. And Taurodontism involves a vertically elongated pulp chamber and short roots as a consequence. So you can appreciate that the crown and the root trunk portion of this tooth is a lot relatively longer than the normal tooth, and that pulp chamber is certainly stretched out in a vertical direction. So it involves longer crowns at the expense of its roots. It's linked to type 4 Amelogenesis Imperfecta, which we'll talk about a little bit later. And lastly, in terms of anomalies of shape, we have dilaceration, which is an abnormal bend in the root, which we can see right down here. It's usually due to traumatic injury to a primary tooth. So intrusive or lateral luxation that bangs a primary tooth into a developing permanent tooth will essentially bend that root that's currently developing. And remember, before we said the later an injury occurs in the development process, the more minor the ultimate effect. And so we can see that manifesting here. This is honestly a pretty minor thing. So it's not really a big deal unless it needs root canal treatment down the road, in which case I'm definitely going to be referring that to an endodontist. All right, and our last category, which is the most crowded, is anomalies of tooth structure. So let's go through these in the next couple slides. All right, first we have enamel hypoplasia. Hypoplasia means that this tissue is being underdeveloped, and it includes a less than normal number of cells. Enamel hypoplasia is due to a failure in the apposition stage, some kind of disturbance during tooth apposition. Turner's hypoplasia And I apologize for this definition, but I just wanted to include it because it's the best wording I could find. Periapical infection or trauma to the primary tooth causes an inflammatory response that messes up ameloblasts of developing permanent tooth. So it involves only the permanent teeth that were developing underneath the primary tooth that was exposed to either infection or trauma. And it's usually on the facial of maxillary incisors, like we see here, or on the facial surface kind of near the cusp tip of premolars. And you can see this kind of brownish tinge of the enamel. That's the result of hypoplasia. So it's due to some infection or trauma to primary tooth, and that leaks into and causes a problem with the underlying developing permanent tooth. So that's really interesting. And you could, if you really wanted to get fancy, based on where it occurs incisor-cervically, you would be able to estimate where, or I should say when, that infection or trauma took place, because we know that as enamel is being laid down, that it's being laid down from the DEJ outwards, and so you could essentially time where, kind of like a tree trunk. In a tree trunk, you're looking at the rings. Here you can see, anyway, it's pretty cool. Way past the scope for the board exam, but just it's very cool how the human body works. And then we also have congenital syphilis, which is another form of enamel hypoplasia. It's very different from Turner's hypoplasia. Here, it's acquired by the fetus from the mother who has syphilis, and it occurs, of course, in the uterus before birth. Now, these features are not pathognomonic for congenital syphilis, which means they're not unequivocally diagnostic, but they are highly associated with congenital syphilis. So Hutchinson's incisors, that's this hypoplastic notch that we're seeing here, here, and in fact, all of these teeth have that hypoplastic notch. Mulberry molars involve this globular enamel that we can appreciate on the occlusal surface of those molars. Enamel hypocalcification. This is an abnormal mineralization resulting in white spots. Can also be like fluorosis, can cause this sort of lesion, and they're very minor. We can see some here as well, very minor white spots on the teeth. So this is a failure in the maturation stage, which is after apposition. Again, here we see the later the disturbance, the more minor the ultimate effect. I think we could both agree that this is a little bit more major than something like this. And something more major yet is Amelogenesis Imperfecta. And I'll be shocked if you don't get at least 2 or 3 questions on these next 2 defects. So Amelogenesis Imperfecta can be autosomal dominant, recessive, or X-linked. Very interesting. It's an intrinsic alteration of enamel. That makes sense because we know from our tooth development video, enamel is formed within its initial matrix of amelogenin. So that's where that name is coming from. Genesis, creation, amelogenin, the matrix for enamel. All teeth from both dentitions are affected, unfortunately. This hits all of them. And the result, thin to no enamel. But the dentin and pulp are normal because this is an alteration, a genetically linked alteration of enamel only. This one occurs with a disturbance, a genetic defect disturbance during the Bell stage. That makes sense. That's when we're getting differentiation of the inner enamel epithelium into ameloblasts that will eventually produce the enamel. So you get this really unfortunate yellow-brown abnormal enamel. In the radiograph, you can appreciate that the enamel layer is significantly thinner than it should be. Dentin and pulp are unaffected. Treatment, full coverage crowns for aesthetics. Dentinogenesis Imperfecta. Again, really, really important. This one's autosomal dominant, intrinsic alteration of dentin only. Again, creation of dentin. Name makes sense, and it's imperfect. All teeth from both dentitions here are again affected. It results in quite a few things. We see short roots, bell-shaped crowns, and obliterated pulps. This is because we're getting these bulbous crowns in the radiographs, these bell-shaped crowns. It's due to a constriction at the DEJ, where this dentin and enamel meet, and it's causing this constricted kind of appearance. And again, it's because the dentin is the problem. The enamel is normal. The pulp, unfortunately, gets messed up as a result of the dentin being imperfect. You also see blue sclera of the eyes. That's a really important high-yield fact that board examiners love to test on. Blue sclera of the eyes linked to Dentinogenesis Imperfecta. Blue sclera is also associated with Osteogenesis Imperfecta, which can be closely associated with Dentinogenesis Imperfecta. This kind of disturbance occurs during the bell stage as well during histodifferentiation. So you're messing up the dental papilla, differentiating into odontoblasts, which are eventually going to secrete the dentin. Again, full coverage crowns for aesthetics if you want to treat it. Next, we have Dentin Dysplasia. This is also autosomal dominant. It's also an intrinsic alteration of dentin, as I'm sure you could guess from the name. All teeth from both dentitions are affected again. Nothing can escape the wrath of these genetic disorders, unfortunately. So we have two types of dentin dysplasia, type 1 and type 2. Type 1, we can see on the left. This is radicular. That means it affects the roots. So it essentially results in really, really short roots. Sometimes people will call them rootless teeth. And as you can imagine, these are going to experience premature mobility and exfoliation. Type 2 dentin dysplasia is coronal. It affects the tooth crowns. It's actually a variant of Dentinogenesis Imperfecta. We get these bulbous crowns, thin roots, and obliterated pulp canals. And it essentially causes these thistle-shaped, chevron-shaped, this is what a chevron looks like, chevron-shaped pulp chambers. So the canals are obliterated, but the chambers in this one are still around, but they have this weird chevron shape. So short roots, chevron pulps, the high-yield facts for both type 1 and type 2 dentin dysplasia. Great things to know for the board exam. How I remember this one, I hold up one finger for type 1. Holding up one finger, it kind of looks like a tooth root. Hold up two fingers for chevron pulps. If I hold up two fingers, kind of make a peace sign, that's kind of what this chevron shape looks like. So that's how I keep those two things straight. These teeth are not good candidates for restoration, especially these where they're just going to become mobile and fall out anyway. All right, next we have regional odontodysplasia. This is known as ghost teeth. That's your high-yield fact for this slide. It affects the ameloblasts, odontoblasts, and the cementoblasts. So everything's affected. You get this disorganized growth of all the dental tissues. Interestingly, it's localized to one quadrant of the mouth. And you're going to get, again, short roots, open apices, enlarged pulp chambers, all this stuff. And like all the other ones we've talked about in this category, it affects all teeth from both dentitions. Radiographically, you can appreciate the really thin enamel here and the dentin. Poor contrast on the radiograph. Large pulp canals with pulp stones, short roots, open apices. Just, unfortunately, a really messy situation. Treatment here, we must support eruption of these teeth as long as possible because they do bring healthy alveolar bone with them. But unfortunately, there's not much else we can do for them except extract them once they're erupted. Next, we have concrescence. This involves the union of two adjacent teeth by the cementum only. As we can see here, it's most common with maxillary molars, where the cementum has been fused together. It interferes with both eruption and extraction. You can imagine that extracting this tooth would be very difficult if it's attached, literally fused to this tooth at the cementum. And it's also linked to hypercementosis extra cementum. And lastly, we have the enamel pearl, which is a chunk of enamel that's blocking attachment of Sharpie's fibers. Here's an example of the enamel pearl. And so Sharpie's fibers are those terminal ends of connective tissue fibers, mostly type 1 collagen, that connects the PDL, periodontal ligament, to the cementum of the tooth root. The patient will automatically have a periodontal pocket because if you're not getting Sharpie's fibers attached, you're not having any sort of attachment of the periodontal apparatus to the tooth, and you're just going to have this free-floating pocket that you could easily have a deep vertical defect there. It will not come off with scaling, which is incredibly frustrating because it's literally a glob of enamel fused to the tooth, and it only occurs in molars. Alright everyone, that's it for this video. Thank you so much for watching. Please like this video if you enjoyed it and subscribe to my channel for more on dentistry. If you're interested in supporting this channel and what I do, please check out my Patreon page. Thank you to Michael Raja, Reb Boyd, Leonilla Bunger, David Jaden, Yanet, Isabella Caldis, Ali Benjgir, Jacob K, Badir Hefnawi, and all my patrons for their support. You can unlock extras like access to my video slides to take notes on and practice questions for the board exams, so go check that out. The link is in the description. Thanks again for watching everyone, and I'll see you in the next video.